Hello, dear viewers. This is part 6 of continuous renal replacement therapy in critically ill patients. In this video, I will be discussing updates and evidence on renal replacement therapy in critically ill patients so clinician can make evidence-based choices in ICU. I am Dr. Sunil Garg from Essentials of Acute Care. Regarding timing of initiation of renal replacement therapy in ICU, immediate RRT initiation is indicated for patients with life-threatening complications such as severe hyperkalemia, profound metabolic acidosis, and significant fluid overload. However, there is significant variability in the threshold chosen to consider metabolic complications and fluid overload to be life-threatening. We will discuss later in the video what threshold is considered appropriate most of the time. But what about initiation of renal replacement therapy when life-threatening metabolic complications, as discussed, are not present in critically ill patients with acute kidney injury? Should we start early RRT in such patients or not? Early initiation may allow for early correction of electrolyte abnormalities, volume status, and azotemia before significant disturbances occur. But evidences does not support this. The available evidence suggests that there is no benefit to early RRT if accepted triggers are not present. Rather, several studies suggest that delaying RRT might be a reasonable approach. This strategy could potentially reduce the overall burden of the RRT and avoid unnecessary treatment in some patients. But question is how much delay? Based on available data, it is defined as if no renal recovery is noted after 48 to 72 hours while patient is in KDIGO or kidney disease improving global outcome stage 3, initiation of RRT will likely benefit the patient. So what is KDIGO stage 3 for acute kidney injury? It is defined by a significant rise in serum creatinine or a decrease in urine output. Specifically, it involves a 3 or more times increase in serum creatinine from baseline or absolute serum creatinine value of 4 or more milligram per deciliter, or in terms of urine output, the urine output of less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours. So, if patient had life-threatening indication of RRT in the form of hyperkalemia, that is defined as serum potassium more than 6.5 with ECG changes and which is refractory to medical management, severe metabolic acidosis that is defined as pH less than 7.15 and unresponsive to sodium bicarbonate administration, and fluid overload which is manifested as pulmonary edema leading to impaired oxygenation and refractory to diuretics, therapy should be started immediately. In other patients, when there is no immediate indication of RRT, it should be delayed and patient should be monitored every 8 hourly for any indication of immediate renal replacement therapy. If patient does not meet indication of immediate renal replacement therapy even after 72 hours of KDIGO stage 3 and there is no evidence of renal recovery, RRT should be initiated. Regarding optimal effluent rate, which is also known as the dose of RRT, is still debated. Large trials like the ATN and the renal studies have shown that effluent flow rate above 20 to 25 ml per kg per hour do not improve outcomes in the majority of patients. Regarding anticoagulation, regional citrate anticoagulation is the preferred method for anticoagulation in CRRT due to its lower risk of bleeding compared to heparin. There is also evidence to show that regional anticoagulation of extracorporeal circuit with citrate as compared to heparin leads to longer filter life. In terms of different RRT modalities, currently there is limited evidence to select one modality over another while prescribing therapy. Continuous RRT means CRRT is often preferred in hemodynamically unstable patients due to its ability to provide continuous fluid and solute removal, and as it occurs at a slower rate, decreasing the risk of hemodynamic instability and intradialytic hypotension in critically ill patients. For patients after traumatic brain injury, stroke, subdural hematoma, liver failure patients, and those with cerebral edema, management of fluid shifts and sodium level is critical in these patients. Hence, CRRT is recommended as the RRT of choice. CRRT gradually eliminates osmotically active substances, mitigating intracranial pressure increase and facilitating controlled mean arterial pressure adjustment. Intermittent hemodialysis may be a suitable option for patients who are more hemodynamically stable, clinical situations requiring rapid correction of metabolic abnormalities such as life-threatening hyperkalemia and acute intoxications are better served by ISD or intermittent hemodialysis because of its ability to rapidly remove through higher blood flow. But what if patient needs intermittent hemodialysis but hemodynamically unstable, like patients with life-threatening hyperkalemia or acute intoxications amenable to RRT management, but their blood pressure is low or they are requiring vasopressors to raise their blood pressure? The use of intermittent hemodialysis in such patients may be optimized by increasing treatment time, increasing the bath sodium concentration, and decreasing the bath temperature. Many patients will transition between modes, means ISD to CRRT or vice versa based on their clinical state. Hybrid therapy such as prolonged intermittent renal replacement therapy like SLAD or EDD finds a balance between the two more commonly used modes. Regarding intravenous contrast, based on current evidence, intravenous contrast is safe in patients with acute kidney injury. So, if you encounter a patient of acute illness in emergency where contrast scans are going to provide important diagnostic or therapeutic information, do not hold the scan because of presence of acute kidney injury. Provide adequate intravenous hydration during peri-contrast period. Regarding which CRRT modality provides best outcomes, it remains unclear whether hemofiltration, which provides enhanced removal of larger size molecules through convection, confers superior outcomes to hemodialysis, which relies on diffusive clearance. So, to summarize, if there are no indication of immediate renal replacement therapy in critically ill ICU patient, it should be delayed than implementing it early. The effluent flow rate above 20 to 25 ml per kg per hour do not improve outcomes in most patients. Regional citrate anticoagulation is a preferred method for anticoagulation in CRRT than heparin. In terms of selection of renal replacement therapy modality, there is limited evidence to select one modality over another in a patient who can tolerate both, except few situations. Intravenous contrast is safe in patients with AKI or acute kidney injury. Regarding modality of CRRT, it remains unclear whether hemofiltration provides superior outcomes than hemodialysis. Here I finish. Thanks for watching this video. Please do not forget to subscribe to this channel. If you have any questions, please write them down in comment section. See you in my next video on CRRT part 7. Till then, bye and take care.